Buongiorno. Today, I have the honor of introducing our Grand Round speaker, Dr. Alessandro Rapichi, who is joining us from Humanitas Research Hospital in Milan, or Milano, Italy. Dr. Rapichi was born in Messina, Sicily, where he grew up and later attended medical school there. His initial training in internal medicine and GI was at the University of Torino. And afterwards, he began his advanced endoscopy training in Paris, and following this devoted more time to advanced endoscopic training in Hamburg and Toronto before returning back to Torino, where he joined the faculty of Molinette Hospital. In 2005, Dr. Repeci moved back to Milano, where he became the director of the digestive endoscopy department at Humanitas Hospital. And in 2007, he became the director of endoscopy programs for all 7 hospitals in the Humanitas group. And it really is at Humanitas that Dr. Repeci truly embarked on a truly outstanding and astounding career in GI and advanced endoscopy. He is regarded as one of the world's greatest endoscopists, having mastered the care of patients with complex GI diseases, using tools such as EUS, ERCP, luminal stenting, resection techniques, including endoscopic submucosal dissection, and POEM. He has published well over 400 manuscripts, many of which are key papers describing novel tools and techniques in the highest impact GI and endoscopy journals. He is currently one of the associate editors of Gastrointestinal Endoscopy. He is one of the leading international and educators in endoscopy and organizes one of the most attended live endoscopy courses worldwide. But this year, Dr. Repeci found himself on the front lines of a battle none of us were really ready for. And as the world watched the first wave of COVID-19 cases overtake Italy, Dr. Repeci was the beacon of light that guided the world through the early stages of the crisis. He contributed the first reports and publications, communications and webinars about safety and patient care in this new COVID-19 world. And with that, he unfortunately became an international expert on navigating the world of endoscopy during a pandemic. So with that introduction, benvenuto a Mount Sinai in New York.
So thank you. Buongiorno everybody. Thanks, Chris. Great introduction. I do not deserve this kind of introduction. Please let me join the congratulations to Dave. Dave, I've seen you over the debate with Marco Chepin, and I understand that being a president is a New York business right now in the United States. If you are far away from New York, you have no space for getting presidency. So congratulations. I know you will do a great job. I will be following you on ACG. And it's a great pleasure, guys, to join Mount Sinai, because when I started doing endoscopy, which was about 30 years ago, I was failing colonoscopy every day. So I was getting so much sad, upset, almost crying, because at the time I was reaching the left colon, I was doing alpha looping. I was keep reading articles from this young and talented guy that is right here watching to us, my friend Jerry Way. I was saying, okay, how I can become Jerry Way in my future. So I dreamed Jerry Way rather than other beautiful things for many months until I was able to get to the Sigum. At that point, I said, I need to go visiting Jerry Way at Mount Sinai. But I was lucky because I met him in Toronto. So if you don't mind, I will share my presentation. So can you see the slide?
Yes.
Okay. So Chris already made the introduction very briefly. I was born in Sicily. And this is the usual scenario that I have in front of me. This is, we do not have a countryside in front of us. We have a beautiful blue Mediterranean Sea. So my holiday is always in Sicily. and I love to spend part of the weekends that I have free going back there because it's a very lovely place. But the change in my professional career was just the move to Toronto. And when you see there was at Wesley rather than in the new hospital like now. And when I was at Wesley, I understand what does it mean training in endoscopy, teaching endoscopy. And I started doing ERCP with this other young and talented guy. I want to tell to all the fellows that we were starting at 7:00 a.m. and we were finishing at 11 p.m. So the average number of ERCP per day was 15 to 16. And for a couple of months, our main role was just bringing patients in and out. So forget the scope, look to these guys. And I will remember Greg Gaber, Paul Cortan, and for 6 months I was astonished. I never saw them doing a single pre-gap. They were always cannulating the bile duct. Incredible. And I'm so glad that I spent a lot of time with one of the guys that I consider the father of endoscopy that recently retired. He is the celebration of the career of Norman Marco. And I know during one of the Toronto courses that I met for the first time, Jerry, and I was fascinated by his personality, his great teaching capability, especially in the field of colonoscopy. I also have a great connection to New York. So I have been in New York at least 35 times in my life. So, and I have 2 suggestions for you guys. My best restaurant in New York, which is top, is Marea, Central Park South. And of course, the best espresso, please. Join me at St. Ambrose, Madison Avenue 1000. It's very close to your place. Best croissant, best espresso, also best lunch, best dinner. So now let's go to the topic, which is COVID and GI. And tell you that it's already been established that patients developing COVID, they may have GI symptoms. You can see they have different kind of GI symptoms. And several times, GI symptoms, they come a little bit earlier than respiratory symptoms. We have published this paper very early because we followed about 350 patients admitted for COVID pneumonia. We looked to their GI symptoms. As you can see, the presence or the absence of GI symptoms doesn't change the course of the disease. It doesn't have any impact in worsening of the disease and ICU admission as well as for death. So when we started doing endoscopy in COVID positive patients, we tried to understand whether or not there was any specific endoscopic pattern associated to COVID. So we couldn't find, we have scoped the 100 patients COVID positive. We could not find any specific findings. And there are a couple of reports of colitis associated with diarrhea, few cases of opportunistic esophagitis. One has been reported from China with very severe bleeding. In general, I would say we can tell to our fellows that COVID is not associated to a specific endoscopic pattern across the entire GI tract. So, and especially in the time of the first wave, we try to analyze which were the endoscopic procedures that have been requested to us for patients who became COVID positive. And as you can see here, across the different months, March, April, and May, which were the most terrible of the pandemic. So the usual procedures that have been required, they were not just because of COVID, but because patients had already had a GI condition requiring endoscopy rather than for COVID disease. So one of the main points of discussion in the beginning was, and this is a question to all of you, do you believe that GI endoscopy is a risky procedure or not? There's a lot of discussion about aerosol generating. So this is myself. I've been recorded with a special camera, and you can see here there are a few droplets coming out when I cough. So it is this is the analysis with a special software of the droplets coming out from my mouth during the cough. So this is why probably endoscopy has been considered as a risky procedure because of the droplets that can come out of the mouth during endoscopy. I tried to make recordings of this with this special camera during several upper GI endoscopy. I was not able to demonstrate a single droplet. And I'm so glad that a group from National University of Seoul Medical School, they did exactly what I have done. They did analysis of droplets using a very high-speed camera, and they looked at this. You see, the first part is artificial droplets. This is a cough. It is what they got during upper GI endoscopy. So they have this nice letter to endoscopy, which has been in press in endoscopy, has been published in the website of endoscopy just 2 days ago. So they use it like we have done a black background, a very high brightness lighting. A footage was analyzed with the post-processing software, dedicated software to see if there are minimal droplets present. So the result is very clear. No droplets were confirmed during the GI endoscopy examination using this high-speed camera photography. So they more or less confirmed what we have seen in our test, in our experiment. And this is also confirmed by many papers. This is very recent review looking to the potential for aerosol generating during upper GI endoscopy, colonoscopy. They were not able to find any significant risk. And again, when you look to this systematic review, this systematic review was published after the first wave of SARS in China in 2003, if I remember well, so about 17 years ago. There were a couple of experts looking to what is a procedure that can increase the risk of transmission of acute respiratory infections, especially viral. And you see they listed the number of different procedures, but upper GI endoscopy is not listed over here. Also, this is a very recent paper published in British Medical Journal just 2 months ago. A lot of papers, different countries, and experts trying to classify the risk of aerosol generating among medical procedures. And you can see here it's upper gastrointestinal endoscopy. It is the procedure with a very high level of disagreement among studies about the aerosol generating. So there is a lot of uncertainty. So I would say the evidence right now is scant. Probably the risks are very limited for, probably nil for lower GI endoscopy, limited for upper GI endoscopy, but it doesn't mean that we need to be brave. I do suggest caution, but not over concern. I think we need to keep working safely. So how you can work safely? As Chris said, in March, we published this first paper in GI, trying to help people in getting the right dress code because we were under the storm of the first wave. So we tried to understand ourselves, how to protect ourselves and our colleagues and our patients. And this paper was inspired by Mike Wallace because he called me overnight to say, Ale, I saw what is happening in Milano. I think this is going to be also the same in the United States. Can you tell us what you're doing right now? Because it will be very helpful for everybody. And we did the Gastrointestinal Endoscopy Associated editorial board just 2 weeks ago. And the guy from Elsevier reported this paper is the second paper with the largest number of downloads over the last probably 20 years. So the first one is ASG lexicon for adverse event. The second one is this paper, which has been downloaded 22,000 times, which doesn't make me proud. I must say this. This makes me extremely sad. I'm not proud of that, because this gives me the sense on how much global is the issue and the problem. So what has been the lesson that we learned at that time? In the beginning, we tried to tailor the approach. More strict rules for high-risk procedure or patients suspected for COVID or with a fever for high-risk patients, and a little bit more general approach with less tight rules for the other procedures and for the rest of patients. This is not going to be the same. Now we have very strict rules for everybody. And I must tell to all of you, especially to the young colleagues, the fellows, so it's not just properly using the PPE. It's a combination of a number of different factors that can help you in work very safely. So it's important that you send a clear instruction to the patients. Triage is very important, social distancing, reorganize the schedule, reorganize personal shifts, of course, PPE, and also careful hand hygiene. Don't forget about this. So there is a lot of discussion about testing patients before endoscopy, and as you can see, there are recommendations by major societies saying that probably 2 days before endoscopy. So overall, I have found 5 guidance from international national societies, and all of them, they do suggest that testing is very helpful at least 48 or 72 hours prior to endoscopy. I think that this is technically and practically impossible in many parts of the world. So of course, I will be very happy to provide to my patients this level of safety, but we are not able to do right now. So right now, we do in Italy about 300,000 testing every day for all patients. We should put on top of this also the test for all endoscopic procedure. I don't think there is the capability. So I think it's very important rather to triage the patients. There are a lot of questionnaires that's been published. I do suggest that the ASG COVID-19 risk questionnaire. It's very simple. You can fill it up in a couple of minutes. And about the pre-testing data, I know also, I've looked also to your paper, and congratulations for your papers. And if you look to the data, so the number of patients who are asymptomatic tested positive is very, very minimal. So we have worked a lot in this area. We did a big Delphi process with about 32 experts from all over the world. And we published this Delphi paper in GATT a couple of months ago. So the agreement among experts was quite strong when we said, okay, in absence of the possibility of testing everybody, at least testing should be provided for those patients who live in very high prevalent regions or for very long-lasting procedures for therapeutic endoscopy. So this is a very important slide for me. This is the impact of triaging the patients before endoscopy. For me, triage means 2 times. The day before, we have a secretary and the nurse, they call on a routine basis patients the day before, they look for symptoms or whatever. And also we have the second triage when they approach the hospital. So these are the procedures that we have done in my unit in the last 5 months. You see, we were at the minimum level. In May, we increased a little bit, close to 1,000. In July, we dropped because holiday in August, and we went back close to September, about 1,000. Normally, we do 1,600 per month in pre-COVID. So if you look to the triage positive, so people that we have identified with as a risky patients because they had the symptoms, they had the contacts with the COVID positive, and the number of patients who tested the COVID positive is very similar. What does it mean, this slide? If you are very good in doing triage, you are targeting the right people who are probably positive. So use triage as much as possible because this is a key. You can save money and time. You can safely work for patients and for the endoscopy personnel. Also, these data, which are not published, are coming from the 7 hospitals. I'm coordinating the GI department, and this is the incidence of COVID asymptomatic. So these are patients referred to us for POEM, ERCP, therapeutic endoscopy. We test all of them with the PCR. It's the number of patients who tested positive and they were really asymptomatic and without any risk factor is very minimal, confirming the data that you have published in Gastroenterology. Of course, the schedule, at least in our experience, is dramatically changed. So we start working at 8 a.m. and we are done at 8 p.m. So we have the same number of physicians. We have a different nurse shift because they are not allowed to work for more than 8 hours. But for the physician, it's much harder. We do not have more physicians. There are no physicians. Many physicians are again relocated to the emergency room because of the second wave. So we have to expand our daily working time. We have more interval between procedures, more time to admit patients because of the triage, and we need more space and more time to clean the rooms. And also we are considering to open on Saturday to shorten the waiting list and accommodate urgencies. So how safe is working in endoscopy? This is our paper in GAT 2020, just I think in July. So we did this survey among 2,300 hospital workers, employee in endoscopy, physician, nurses, any kind of person working in endoscopy. And we were able to demonstrate that once we realized the magnitude of the problem, we start using properly PPE, the risk is very minimal. So with PPE, which is the lesson that we have learned. So this is myself doing ERCP yesterday. So you see what is our regular setting, and I'm not considering this as a short term. What I tell to my fellows every day, just try to get used to this, because this is a long-term approach for the years to come. So we are going to change our behaviors and our attitude, and we will be protected for many years to come. Of course, it is an impact for the cost. This is my estimation at the Italian cost of the devices that we're using every time for each diagnostic endoscopy procedure, for each therapeutic. It is a huge impact on the budget. So for next year budget, I already allocated enough resources to cover these expenses, because these are not expected. And when you think, oh, just $5 or $10, if you multiply this for the number of procedures and the number of people attending endoscopy, is catastrophic budget. So make sure that you are considering this in your next budget. So in conclusion, what I can tell you is that there are no COVID-associated conditions specifically requiring endoscopic procedures. The practice of endoscopy must be changed, but can restart, I think, at the same level like before COVID, very safely, if we consider all these issues that we are discussing today. A safety is not just PPE. Just for my young colleagues, I will never stop to remind them safety is a combination of multiple actions. Don't forget that. And the risk of cross-contamination in endoscopy facility is quite low, so reassure yourself, reassure your family. I hope to see you soon, guys.
Thank you very much.
You know, my patient is New York, so I bring my family almost every summer. And almost every summer we have about 10 pictures every year we come in New York in the Brooklyn Bridge. So thank you guys. If there is any question, I will be glad to answer.
So, Alessandro, thank you so much for sharing your experience and expertise in all of this. While people are thinking of some questions to ask, maybe you can just give us a sense of what's happening in Italy now.
Yeah.
And I'm particularly interested to know, culturally, how does the population respond to wearing face masks just out in public? You know, in the United States, there are still large pockets of people who are not compliant with wearing a face mask, who are not social distancing, who are, behaving irresponsibly in large groups and that sort of thing. You may have seen some of this with our own president, but maybe you can relay some of what's happening in Italy right now.
Yeah, thanks, Chris. So we are under the second perfect storm. So in summertime, everybody was relaxed and we forgot a little bit. So now we have a huge number of COVID positive. So about 13% of all people tested in Italy every day are turning positive. And we have a significant pressure on the hospitals. So the difference between now and the first wave is that we have, again, a lot of pneumonia, but less people requiring ICU admission. To give you numbers, so beginning of April in my hospital, which is 750 beds, we have 400 pneumonia admitted and about 65 admitted in ICU. And we had for a couple of days, more than a couple of days, one death every 15 minutes. So more than 24 deaths per day. Okay. So right now, after I would say 2 weeks that we are witnessing the second wave, we have about 250 patients admitted for pneumonia and only 12 in ICU. And the number of deaths can be counted on a single hand. And the same is in the other hospital in Milano. What is the difference? The difference is that now, since we were trying to get back all the patients that we have lost in this first wave, we have a lot of surgeries for oncology, a lot of chemotherapy, a lot of procedures to be done. All hospitals are fully booked. So there is overlapping of patients requiring our care, patients requiring treatment, and patients admitted for COVID. So we don't know how to manage that. With regard to the people, I think that we have less issues as compared with the United States with regard to the fact that people are not wearing masks or they are saying that this is not an issue, it's a problem. The minimal amount of people being, I would say, too much superficial approaching this. But why this? There is a reason. When we had the first wave, it was dramatic, but it looked like a very distant situation. If you were not in the hospital, it was not common to have a relative or a friend COVID positive. If you ask to any Italian right now, everybody has a person in the family, everybody has a friend who is positive. So now everybody has the awareness that we are surrounded by COVID positive. So if you do not pay attention, you will get positive. And of course, many are asymptomatic, but you don't know if your lottery is being asymptomatic or getting pneumonia and being intubated in 5 days. So this has been understood very, very on a large scale. So people are paying a lot of attention.
Ali, thank you. Thank you for joining us this morning. Thanks for the kind words about the ACG. That was very nice. Appreciate it. And the New York connection. But you're being ridiculously modest in terms of, the impact you had on us in the United States and around the world initially. So if you go back to March, Ali was very generous with his time and, appeared on every webinar that was possible to sort of like alert the folks in the United States about what was going on in Italy and Europe. And that article that you published was landmark because it gave everybody some guidance to start out figuring out how we were going to sort out being safe. And that was critical. So it's not surprising to me that it's the second most downloaded article. And the figures, obviously were used very, very widely. So we owe you a debt of gratitude for the time you put in teaching us all what to do. One of the things that I thought was most reassuring, though, ultimately, when we talked to you then and then over the summer, was you were able to show that using PPE and other safety measures, and the point you make about safety is not just PPE is really critical. I mean, it's a whole program that includes PPE, but you were able to show very reassuringly that program worked. So you were able to show initially that a lot of the healthcare workers in gastroenterologists and the technicians and so forth got sick. And then pretty soon, once we figured out what was going on, they didn't get sick. And so maybe you can talk a little bit more about that to reassure the group here that have found the same thing, but it all came from you to start.
So David, thank you for your comments, very generous of you. So I want to give you another data which is not published. We are looking now, we are following very carefully all people working in different endoscopy departments across the northern part of Italy who are getting infected, COVID positive, whatever are the symptoms, also asymptomatic, no? So for example, in my unit, we have 2 nurses. In Milano, there are about 4 physicians who turned positive. In Torino, there are 3 physicians. So we try to understand what is the connection with the infection, how they got infected. I would want to tell all of you that 90% of these infections were taken out of the hospital, mostly by kids going to the schools. So we understand how much important our kids that keep going to the school. I do insist that this is crucial. I want my kids going to the school. I know this is creating some troubles. This is a price to pay, but the main take-home message is that endoscopy and hospital are very safe. We are not the people contaminating patients or contaminating other hospital workers. So the infection normally comes from outside rather than inside.
Perfect. And I shared that picture you showed with Greg Haber already, who wrote back and said, so great to see you in the early days.
I also texted Greg that.
Greg was young already at that time. Don't worry. He was about 12 years old. So
Ollie, thank you for that great talk. I also texted Greg.
Thank you guys, and enjoy your time in New York. Ciao.
Thank you.
Bye-bye, guys. Good luck to all fellows. Ciao. Ciao, ciao.